Okay? To understand how copying works in restorative or digital dentistry, we have to think backwards a little bit. Let's imagine an intact tooth, a beautiful natural shape. And for the sake of the conversation, let's imagine that we need to prep a crown or a veneer. So let's say we have a beautiful uniform preparation. And design of the restoration will be initial shape minus preparation. If we mill this restoration, we will get a very, very precise copy. When we restore lost dentition, in most cases, we don't have this piece of the puzzle. We don't have the initial shape. Look at this case. There's no initial shape. It has been lost long ago. The only thing we have is a space of possibilities and of libraries we can use within this space. Which means whenever we're going to select any other shape other than its initial, which is long lost, there will be a discrepancy between the prep line and the copy line. Which means a very simple math here. The bigger the discrepancy between these two lines, the worse the copy. The smaller the discrepancy, the better the copy. Now remember that the shape is designed to fit this particular scenario. You have used SmileCloud, which means the shape has the right size, the right proportion, the right contact area, the right papilla height. Now when I'm placing this shape, I want it to be in close relationship to where I can place my future prep. This means there are two crucial moments in the workflow for achieving as close to perfect copy of a natural shape. The moment you place the shape and the moment you place the prep. When you're placing the shape, what you're thinking as you're doing that is, can the prep be placed here? That's the one thing that you have in your mind as you're closing in on the final shape position in relation to the prep. This is what you're asking, because the prep has not been done yet. It will be done in the future, but as you're planning now, you need to plan for something which is possible to be achieved. The second thing to consider is the relationship to the tissue, or even more specifically, the relationship of the future prosthetic piece with the tissue, aka the emergence profile. There are two very important things to consider, especially in this case where you crown lengthen. One, maxilla is centripetal. As you go up, it goes in. Means the more you crown lengthen, the more aggressive your teeth profiles will become. Second, you have to imagine that your prep is on a structure that's under the tissue, anywhere from 1 to 3 millimeters depending on biotype, but is always closer to 3 than to 1. Now these two combined, the fact that both the maxilla is going in and the structures are also in a more palatal position, can lead to huge discrepancies between the, where you place the shape and where you can in the near future be placing realistically the prep. And this can result in a lot of frustration in the design process, because essentially if you disregard these factors, you are designing something that can never be achieved in reality. ignore the cameras, okay? I mean, you will get to ignore them after a little bit. Don't worry about them. We will take a short video before, just so we can see the mock-up right now. Yeah, after that we will go do the mock-up, come back here, film again, put on a screen, and see what we need to achieve today. Everything is like, you know, normal, except there is some guys that we need to just pretend that they are not here while we work. Okay, so what do we have here? Well, obviously a congenitally missing laterals case, and maybe also a gummy smile. We see, let's say, slightly more gingival display than we would expect, but that's not necessarily a problem. However, congenitally missing laterals tends to be a problem because of the space distribution, which, if we go to an occlusal view, you can see what I mean. If we want to solve this case prosthetics only, it's going to be virtually impossible, because there's no way that we can have nice proportions in existing, let's say, teeth position. Which means two options. Option number one is the classic option. In the classic option is you open the space for laterals, place implants in lateral position, restore the implants. Why is this the classic option? Well, mainly because it's a more conservative option. In theory, you can finish the case with just ortho treatment, obviously, which is mandatory for both ways, which we're going to discuss, and two implant restorations, supported, of course, by two dental implants. What is the other option? The other option is the opposite. You close the spaces, you shift the canine mesially towards the central, closing the space, then you move the premolar into a canine position, and then you combine this with the restorative treatment to convert the canine into a lateral and the premolar into a canine respectively. We are going to have the implants to premolar-molar position, which on the long term, of course, it's a safer option regardless of how proficient we are in implant surgery or in pros. Let's go to the next part. We will do the bone with an ultrasonic tip. This is the CV dentus. After you cut the tissue, you need to reestablish the biological width. So imagine that the bone should be 3 millimeters away from the area that we recontour the tissue. Okay. Now, in the classic way, you would probe, and if the bone is doesn't have the amount of space, which it doesn't here, in the classic way, you open a flap and you recontour the bone. However, what we have been doing a lot of times lately is we do this procedure in a flapless way with an ultrasonic tip, which I will show you in a little bit. You simply go in 3 millimeters. The length of the tip helps you because it is 3 millimeters, and you go and just recontour wherever you touch the tissue.
Quite like what I see here. This shouldn't be in white, but sometimes this happens. So I'm going to go to freeform again.
always in a relationship with the technician, in every case. It's your professional wife, yeah? And you know what they say, happy wife, happy life. So make your technician happy at this moment if you want to be happy when the trying comes. See, this area you still need to remove. Here is more than enough space. It's nice to have a gradient like this, but it has to be, a space that is millable. So just in the cervical, a little bit. Measure in the middle, please, because there it's clearly enough. Okay, so the idea is, ideally, is to have a gradient in the prep for monolithic. You want, the ceramics to be thinner in the cervical, you get more chroma from the tooth. You want more value in the middle, so more ceramic, and then you have the clearance for the opalescent in the incisal edge. So just a little bit I need to do in the cervical, but that's perfect. Why? Because I haven't done my chamfers yet. So that's exactly where I will touch now.
As Florin said and I said, the main point of doing both options is for you to decide. So imagine if you don't have a lab, you did everything before, now it's time to do everything in the mouth. So I take the provisional cylinder, okay? I go in. Let's try the provisional with the cylinder in position. Do you feel pain, my friend? Feeling pain? No, it's okay. Okay, can you give me the mirror? Very, very nice. You see, it's there, it's in position. I have space, and I asked the lab the space that you see here, you see? So I can use flowable composite here to capture this position, right? The wings will give me exactly the position, you see? Let's just take some flowable composite and connect everything. My brother wants to cut a little bit the cylinder first, outside of the mouth. He's just going to do just a point in the buccal, so we know that this is the buccal area. Just a small mark. We remove from the mouth. We are just going to cut a little bit because it's too long. We don't need it. Let's take a metal burr now, and we are going to cut just a little bit of the cylinder. Okay, let's go back with the cylinder. Just cut a little bit, and we go back. Great. The components are yellow, anodized in yellow color, but in order to have a very nice result, we always like to use an opaque composite here in the buccal area, okay? So we just dry very well, and we apply this composite material here. As you can see, this is a flowable composite. It's beautiful opaque from Shofu. It's a very opaque flowable composite, and it's nice to really hide the color of the metal. So we are just going to add something a little bit here in the buccal area. Okay, nice. One step also that we really want and do it's create some small retentions inside. So we just take a burr, a small burr, and we create some small retentions. So you see here, just a simple thing, but helps a lot with the composite. So just small retentions inside with a round diamond burr, and then we move to capture the position. Let's clean and dry. Super. I put the provisional in position. Just need to feel that we are perfectly in position. Let's check the buccal view here. Okay, we are. I hold the two wings. I take my flowable composite. There. Light cure. Okay, the cylinder is captured. Look at the nice format of the lateral, very well positioned. You see here that I put all the way with the flowable composite. So let's unscrew.
In the first stage, when you relax a patient, especially with splints, they decompensate in the first moment, which means the muscles become more relaxed, because imagine like the deep muscles also contract the superficial ones. So the second that she becomes more relaxed, you will see more gingival display as everything relaxes. Plus, you will see a bigger shift. The chin, the menton, is in a different position, which means many times in a case like this, after the first stage, the case looks probably worse than the beginning, but this is normal. And then you have to do the orthognathic jump. The orthognathic jump is basically intrude the maxilla surgically, and then you have also repositioning of the lower jaw. This happens. Now you see that again here in the area that I fucked up, we kept the calm, and when I prep, I just prep here. I don't go like this. And then we get to the point where we can try everything in. And at this point, we still have my master full crown lengthening and the color of the tissues to fix. Trying everything, and then again, Gustavo and Marcelo.
Yes, sure. The same, exactly the same as last time, but just on top of natural teeth. So now I don't need like a lot of tissue, okay? Imagine like the previous case I had to add a lot of tissue, so I decided to remove a lot. Again, here, I don't want to create like a bulky situation because it's going to be very weird at the end of the treatment, right? So in order to block the color here, there, and to bring the tissue down here, I need like 1.2 millimeters of soft tissue is more than enough, but I need to create space for the graft, because otherwise I will be like here with a lot of tissue, here different profile, and everything is going to be really strange. Go back one picture.
In this next season, we'll continue to talk about design from an idea of, looking at the problem, understanding the problem, and then obviously having an assumption of how to structure the treatment plan or what to base it around, and then how to convert this into an actual design. And for this reason, I think it's relevant to go complex a little bit in terms of the cases we will talk about. And I deliberately chose 2 cases which have something in common. Basically, everything is gonna change in both of them. If you look at this picture, only pretty much the upper part of the face will stay unchanged. Everything else will change.